So have you seen the videos where someone will go around and ask Americans like questions about American history, and they don't know, they never know the answer?
They'll be like, yeah, but they'll ask like simple questions.
Well, yeah, they'll be like, well,
They'll be like, how many states are in? I've seen people be like, how many states are in America? And they're like, oh, at least 100.
Yeah,
Like
exactly. So I feel like part of the reason is because we're not teaching history the right way.
Okay.
Because I was reading the other day about Andrew Jackson, the president, and how he's rumored to have like fought in like over 100 duels. He would just duel people all the time.
Wow.
And I was like, I never learned that. Like, that's super interesting. So I decided to look into it further. True story. Andrew Jackson was the first president that someone attempted to assassinate. Okay?
The first one that
attempted to assassinate, right? This guy comes up behind Andrew Jackson. This is a true story. Walking down, and I never learned this, and I feel like people would know history better if you taught this kind of stories. He's walking down the steps of like the Capitol building. A guy comes up behind him, pulls out a pistol, fires. Well, it misfires because it's like a humid day, and like pistols by then. Pulls out a second pistol.
His back up.
Yeah, misfires again. At this point, Andrew Jackson turns around because he obviously like and starts beating the guy with a cane. Now, here's where it gets more interesting. The story goes, Davy Crockett had to step in and pull him off the guy because apparently Davy Crockett was a U.S. senator. And I'm going to be honest with you, there's a good part of me that thought Davy Crockett was a fictional character. I just like, and I'm like, if we were teaching this stuff, I feel like people would understand.
It's like Game of Thrones or something. It's like, remember that scene? I would always remember that. Mm-hmm. Also, like, that's so much more relatable. I can relate to somebody.
I can relate to that.
I can relate to somebody who beats someone mercilessly.
I have a dime for every time Davy Crockett had to pull me off of somebody. Like, no, it's just like,
I know what I'm saying. It makes these like, I think like American history, we have this way of like mysticizing, like these are like mythical characters almost. But like when we get to see them do stuff that's like very human, like try to kill each other or duel 100 people. Like, was Andrew Jackson like? Was he actually savvy and political, or did he just kill all his enemies?
I think he killed like a few people in duel. It's just like an okay way to kill someone back then.
I love that like we act like that was such a better, more civilized time, but all you had to do is like smack somebody with a glove and you could go shoot him in the backyard and it was completely legal. Yeah, so it's great.
All right, cool. Well, welcome to the Back to Basics podcast. I am Chris Seitz. I'm an emergency physician, and I'm with my brother Jason Seitz, a firefighter, paramedic, and RN. And on this podcast, we like to break down what are sometimes complex medical topics and bring them back to the basics and make them easy to understand, hopefully, so that you walk away with a little piece of new knowledge that you maybe didn't have before.
Awesome. So, quick note, if you were a paramedic, an EMT, first responder, MFR, EMTI, there's a bunch of them.
EMR.
But if you're a pre-hospital provider, you can get a continuing education credit for listening to this podcast. So check it out at guardiancme.com. You can go there. I would stop listening to it right now and listen to it on there instead, so you don't have to listen to it twice. Take a quick quiz. You can get a credit. It's a CAPC credit, so it'll work at any of your accrediting bodies. So check it out there.
Cool. Awesome. Well, what are we talking about today?
Today, and I'm actually more excited that you're going into this one cold because I did the research for this one and I'll be talking about it. So because we haven't touched on any of this in any of our previous podcasts. In fact, I don't think we've even talked about this side of medicine at all. We're going to talk about psych conditions.
Okay.
So I'm calling it mind trap.
Mind trap. I like that.
Yeah. Anyway, so psych conditions. So here's what's tough is I think that we're going to need to come back to this topic maybe a few times.
Sure.
We're going to get kind of like a bird's eye view of psych conditions, talk about the general most common disorders that we see. But there's a couple like caveats. One is we're not going to get super heavy into like treatment of these conditions. I would like to come back and talk about the pharmacology that's involved in certain psych conditions because there's like a lot of interesting stuff and there's a lot of interesting stuff in how that plays pre-hospitally and in the hospital and how that can relate to other psych conditions because the medicines that they're on, behavioral, changing meds. That's a whole nother world. It'd be fun to talk about.
Well, and all the dopamine, serotonin, and like too much of this, too little of this. Like it is, it's very.
Well, and tricyclic antidepressants and the overdosing of that you can see very easily. So there's like a lot of like fun stuff to talk about within. I don't know if that's fun.
It's super fun.
But for me, interesting stuff to talk about within just the medicine side of that. But first, we kind of have to understand the conditions. So I think this isn't a part one per se, but I think that we'll be coming back this year or next year to talk about, probably early next year to talk about meds used in psychology, psychiatric stuff.
I like it.
Cool.
Another caveat I think we have to throw in here is that these are ever changing terms and definitions in some ways. Like a lot of research comes out. I mean, it's mental health. Like we're learning in the most recent future, like the last few years, even so much more around mental health. So especially in psychiatry, we define certain conditions, which sometimes does us a disservice. Like we have to define them in order to like understand them well and be able to like develop treatments but we do sometimes try to like, when we define something, we put it in a box. And I think as most people know nowadays, like you can't really put mental health in a definable box. So as we define, I guess the caveat here is that as we define these things and talk about them, we're basing this off of references and things like that. If it seems a little bit off, or like maybe you've heard something different, like that's fine. I mean, like we're not trying to say like this is the end all be all definition of bipolar disorder or schizophrenia. I mean, like we're going to try to describe the boxes that have been presented to healthcare thus far, but recognize that like these don't necessarily always fit in a box. Does that make sense?
Yeah, right. I think like the audience will see it as we're going through these. So many of these are tied to each other in weird ways. So like it's hard to be like that is a psychotic disorder, or that is a mood disorder, or that is a behavioral disorder, because like a lot of those you'll see the other symptoms kind of popping up in it. As an example, like schizoaffective disorder is a form of schizophrenia, but it also has a lot of mood disorder symptomology like kind of mixed in there. It's considered less severe than schizophrenia would be, but more severe than most mood disorders would be. So it's like this kind of odd, and you have to understand like as mental health providers like find particular situations, like they have to define that too. And every patient is different, every mind is different, and there can be a lot of, you know, it's not as simple as, you know, if there's a blood clot here, we call it this. You know what I mean? It's such a sensitive, misunderstood part of our body that like we're really like cutting edge on some of this stuff, which is cool. So let's get into it. So first, let's start talking about psychotic versus cognitive versus behavioral. So a psychotic condition is something that causes abnormal thinking or perceptions. And namely, the two examples of that would be delusions and hallucinations. So delusions would be, well, give me an example of a delusion.
Well, a delusion is essentially like in your mind, like how is a perception, like you're perceiving a situation a certain way, or you think you're somewhere that you're not. A hallucination is actually seeing, like visually seeing or hearing, like audible, like.
Yeah, there's like a sensory application when it comes to hallucinations. Like delusions, I might think something about something that is not based in fact. I might think that movie star is in love with me. A hallucination is like I see a movie star that's not there over there.
Right.
You know, so those are kind of the most serious psychiatric conditions are usually psychotic conditions. All right. So. Well, as we just kind of jump it through a few of these, one thing I want to talk about is cognitive disorders. So two cognitive disorders that we see the most are delirium and dementia. So delirium is widespread disorganized thought, and it's relatively rapid onset, and
it's reversible.
It can be reversible, right? Which is great. Dementia, on the other hand, is a little bit different. Dementia it's complex. There's a myriad of symptoms with dementia, but it's basically like a gradual memory impairment, like it's a breakdown of that, right? Cognitive disorders, delirium and dementia, are usually caused by like brain injury or disease, so a little bit more of like a tangible damage to the brain tissue, right? So in dementia, we'll see memory impairment, we'll see impaired judgment, we'll see difficulties thinking abstractly. We'll see a couple symptoms sometimes. Like sometimes it's paired with aphasia, which would be like I have trouble speaking or like my verbal explanation doesn't make any sense. Apraxia would be motor dysfunction without the loss of sensory dysfunction, right? So like in a neurovascular disease, when like my neurons are damaged, I can't. Right? In this case, like you can, but you don't, if that makes any sense. So I'm having trouble grasping something, even though I can feel it. In a neurovascular breakdown, you're having trouble grasping something because you have sensory dysfunction, right? Agnosia is the same thing. It's the recognition of objects. It's like struggling to recognize objects, even though you can see and perceive those objects. And then executive functioning issues a lot of times, planning, organizing, sequencing. This is where we see, in our elderly population a lot of times that develop dementia, difficulty like those judgment calls and with doing kind of those advanced, more complex thought processes.
Examples of that is the difficulty balancing a checkbook, or difficulty like remembering like phone numbers and things that, you know what I mean, that kind of executive, like just the executive function. And typically, like, again, the big defining things between delirium and dementia is what you kind of said, that rapid onset in delirium versus the slow onset in dementia, the reversibility of delirium in a lot of cases, and dementia's, you know, not. So it's like, you know, you don't wake up one morning and you're like, oh my gosh, that guy had dementia today. Like he developed dementia today. Like that doesn't happen, right? It may not be recognized for a time because it can be easily hidden.
Yeah. And then so when it comes to dementia, one of the main causes of dementia, the most common cause of dementia, would be Alzheimer's disease, right? But other things can cause dementia, right? It could be injury, it could be traumatic injury. So there's Alzheimer's disease as a disease process that can lead to dementia symptoms, but they're not mutually exclusive.
Well, and then there's neurovascular dementia, where you have like so many mini strokes and things like that, where you have like multiple ischemic injuries to the brain, which then leads to dementia. It's not reversible, right. You know what I mean, that kind of thing. So yeah.
And that's why I kind of wanted to start with cognitive disorders, because I think they're a little bit more tangible with the other topics that we talk about, like medical topics, injuries, you know, internal injuries, things like that. Like we can understand that a little bit better. Then we start getting a little bit more confusing as we get into things like mood disorders. So mood disorders are obviously disorders that are affecting your mood. A lot of them are caused by a suppression or an overproduction of certain mood stabilizing chemicals in your body, right? For instance,
dopamine, serotonin.
Yeah, dopamine, serotonin, things like that.
Really what's interesting, this is why it'll be interesting to do another podcast on the actual like chemical, because like all of these, I mean, not the cognitive, but like even the psychotic disorders, the mood disorders, like they all have to do with just like 3 chemicals.
Yeah.
Which is kind of crazy.
It's crazy. Well, we shouldn't say it's crazy.
That's a good point.
Yeah, it's probably stay away from that word in this podcast.
All right, fair enough.
Turn of phrase is what we're referring to.
There you go.
So mood disorders, main one that we think of is depression, right? Depression affects many people. In fact, whoever's listening to this has probably experienced an acute depression in their life before. Like that can be very common, you know, feelings of sadness. But major depressive disorder is a little bit different. It usually you need to have 5 symptoms in a 2-week period of time consistently. And again, like Chris said, it has to have an interruption in your life cycle in some way, right? So some examples, you no longer have interest in your old hobbies. You're thinking about death and suicide. I don't know, give me some more.
Like sleep. Like
there's
a sleep component in a lot of things. Yeah, where you can't sleep.
Anxiety. Under this, I talk about suicide a little bit in my lectures when I discuss mood disorders. So like suicide, it always bothers me when people are like, and then another mood disorder is suicide. And it's like suicide's like an act. It's not really like a disorder. So we're talking about like suicidal ideations or thoughts of suicide, you know, intrusive thoughts about suicide. Like that is a very serious symptom that can sometimes almost be broken down into its own condition. It usually is connected to major depressive disorder, but it is very important to recognize that symptom and address it very quickly. So like we don't like, you're never going to give someone the idea of suicide, right? Like people know what suicide is. So like if someone who's super depressed, if you ask them outright, hey, are you thinking about killing yourself? They're not going to be like, never thought of that before. And then like run and jump off a bridge or something like that.
But
right?
now
like,
I am.
Right. So it is very important. Like we have found so much in mental health, like asking that question has changed so many lives and saved so many lives. Just asking the question, are you having thoughts about killing yourself? Or like, have you had a plan? And being able to have those discussions, they can be uncomfortable maybe, but having those discussions with people really changes lives. Like,
and typically when you're suffering from a mood disorder, or even like, I mean, the cognitive one's a little bit different, but a mood disorder, psychiatric disorder, I do this all the time in the emergency department where like you can ask those questions. There's no taboo to that person. This is what they live. So of course, they're like, yeah, I do have those things. And yeah, I do see people over there. Like they're not trying to hide it most of the time. I mean, they're being very honest and open. Like they want the help too, if they, you know, so.
And we'll talk about this a little bit in treatment, but it's so funny to me. Like if you parallel this to like if you have symptoms and you have a really bad sore throat and you come into the doctor's office and you say, my throat is killing me, it's giving me anxiety, it's frustrating me, and they're like, oh, you have strep throat. That's normal. It's normal in strep throat to have those symptoms.
Yeah.
You feel a lot better about it. And hey, you know what? We're on a path to recovery for it, right? In the same way with psychological conditions, I can't tell you how many times I sat in the back of an ambulance with someone and was like, are you thinking about hurting yourself, or like, do you have like intrusive thoughts, or do you like see somebody over there or anything like that? Are you hearing voices? Like, just asking these direct questions and then being like, yeah, and looking panicked, and me being like, that's okay. Well, that's normal. Obviously it's not normal in a healthy individual, but that's normal for your condition right now. And them hearing that information, oh my gosh, it just changes you build this rapport with the patient. It changes your whole outlook on that and their whole outlook on it. It's so important for them to know, like, this is a normal thing to be experiencing in this condition. It's treatable. We can get it handled for you.
And in the same token there, like, you go into the emergency department because you think you have strep throat and your throat hurts really bad. And like, you also have, let's say a fever. And I'm like, have you been feeling feverish? And you're like, no, like you're not trying to hide. You're gonna say yes. I mean, it's like clearly like part of the you came in. That's why you're there.
Well, and also you're not going to avoid the topic of fever with that strep throat because it could like scare me or like set me off or something. Like that doesn't make any sense, right? So I really think it's important to like be communicating with these patients and be honest with them and reassuring them that like, hey, it's totally okay that you're seeing somebody right now or you're hearing somebody. Like they're not there, and but it's okay that you're hearing that, right? Yeah. So bipolar disorder is another mood disorder, right? Bipolar, you can think bi meaning two, polar opposites, like two sides of the same coin kind of thing, right? And this is where I think we can all relate a little bit to like bipolar disorder in the sense that like manic episodes, at least I can relate to manic episodes. Like I have a tendency to get manic and excited about things, not to the point where it's interrupting my life, where it's a condition, but you can see how this is a function of our mind that can't have dysfunction within it and go too far.
And
right?
everything ebbs and flows, right? So on the other side of depression is mania, right? These are the extremes.
The two
and of
polar
course,
sides.
This especially from a spectrum standpoint, like we all on a daily basis ride that wave of like being a little bit down, being excited. Like that's not mania or depression, right? That's just living. That's just being a human being. Mania, though, again, is when it becomes disruptive. And typically the way we diagnose like manic, is that all of a sudden these people are engaging in very risky behaviors. Maybe they're gambling. Like a lot of the ones are like they start like gambling away all their money, or just spending all their money, or they are doing very like risky sexual things. Like they're putting themselves at risk.
Yeah, and this is where you can see these conditions playing into each other. Delirium can very quickly play into a bipolar mania because now I'm gambling all my money because I'm having delusions of grandeur that I'm the chosen one and I'm going to be able to make that money and everything's going to be fine, right? So like mania is basically like manic behavior is basically the opposite of depression, very uppity to behavior. Bipolar disorder can be just mania on its own, or it can be like manic episodes followed by depressive episodes like intermittently, right? So it doesn't have to be both. So moving on from mood disorders, we can talk about schizophrenia. Schizophrenia is like, it's the big obvious one that we think of when we think of psychiatric disorders. It's actually very common. Schizophrenia happens in about 1% of the population, which is interesting to me. We think of it as this like rare thing, but no, it's very common. Schizophrenia represents basically a significant change in behavior, and usually we have hallucinations, delusions, and depression with it. So
and then suicidal ideation can come with that as well. A lot of times with schizophrenia.
Correct. Yep. So there are a bunch of different forms of schizophrenia that it's worth kind of just covering real quick. So I'll probably miss some of these. I didn't list all of them, but there's like a paranoid schizophrenic is someone who has like this feeling of persecution, right? So it's not in reality, but they have this feeling that like everyone's out to get them, or someone is hurting them, or someone wants to hurt them, right? A disorganized schizophrenic would be like, this one's interesting. It's like regressive and primitive. So like basically like a lot of like higher behavioral functioning is like suppressed to the point where they're so disorganized in thinking that they'll like act like a primitive person. Really like regressive behavior, meaning like not relying on like higher order thinking processes. Catatonic would be, this is like the most rare type of schizophrenia, but catatonic would be like you go into a catatonic state, right? You just kind of like zone out, flat affect, not responding to the environment around you. Undifferentiated would be like the schizophrenia where it's like you don't really quite fit the other ones. Right. So we always have something like that. As I mentioned earlier, schizoaffective disorder. This is like a subset of schizophrenia that plays highly into mood disorders with it. That we'll see a lot of depression like tied into that. It is considered a more serious mood disorder, but a less serious schizophrenia. So it kind of plays into that. And then there's residual schizophrenia, which would be like you had an acute episode of schizophrenia where you had psychotic symptoms, and now you still have some symptoms of schizophrenia without the psychotic symptoms. So like maybe you had a schizophrenic episode, you were seeing hallucinations and delusions, and then like now in between that, like you're struggling with some depression, but you're not having any psychotic sensory changes.
Awesome. So the next kind of like category. What?
It's category. I don't know why you ever say category.
I don't know.
Category sounds like an Australian
how to say that word right there.
Animal.
A category.
Oh, well, that's a category.
Category. All right. Anyway, the next category of psychiatric disorders would be impulse control disorders. It's kind of in the name. So these are the things like kleptomania, right? Like people who cannot help but steal things. Pyromania, people who cannot help but set things on fire.
Yes.
Like there's just like any like they literally cannot like withstand, like they can't not do it. You know
and we
mean?
see this can be developed through actions. You know what I mean? That's what's
well. What's interesting about this is that if you think about, and this is impulse control. I mean, like we haven't defined this yet. I would not be surprised if maybe we do in the future. Social media. Like they've done the research. There is every time you swipe, every time you get a like, it's a dopamine dump. Mm-hmm. And that's what all this stuff comes down to. It's dopamine, serotonin, norepinephrine. So if in an impulse control like kleptomania, you steal things because you get that dopamine high every time you do it. Same with pyromania. Let's set things on fire because we don't see kleptomania and pyromania as much anymore. But I wonder why, right? Because where are we getting our easy dopamine dump? I mean, think about how many times you get on social media and you just scroll, and you just literally like almost can't help it. Like that's.
Do you have TikTok?
What's that?
Do you have TikTok?
No, I don't.
TikTok has this thing where it'll like actually tell you like, hey, you've been scrolling for a little bit too long.
Yeah, that's good.
I hit that thing all the time.
Right.
And Natalie is like so judgmental about it.
But again, like you said, like these behaviors can like build into an impulse control issue because again, it's our brain becoming addicted to the dopamine dumps a lot of times. So that's gambling, even alcoholism in some ways is an impulse control disorder in its own way. So,
and that's what's interesting is that like it's not. So if you enjoy TikTok and you're getting dopamine dumps and like that's fine, you don't necessarily have an impulse control disorder. If you are unable to stop. Like that's the whole like joke we hear about the whole like, oh, I can stop whenever I want to, but they can't, right? That's when it becomes an impulse control disorder. Like you are not able to say no to the dopamine.
And it starts to disrupt your life, right? Mm-hmm. Like I'm scrolling through TikTok so much that I don't go to work and lose my job or I lose my marriage because you mean like this is what happens with like pyromania, kleptomania. Like you're like,
well, I would argue that they're always disrupted because those are illegal things, right? They're things that you are not allowed to do. Right. So the minute you jump into that impulse the first time, it's illegal. That's an impulse control. Like you should have been able to control yourself to not set fire to.
And that's what I'm saying. Like they're causing harm. Yeah. Right. There's that extra. Like even like drinking alcohol on a regular basis is not necessarily causing harm. When it starts to cause harm, now it's alcoholism. Right. I mean, like this is like where we have to like. That's why we define these things in this way.
Yeah.
So the next ones are dissociative disorders, which are very interesting.
Yeah. So these are like the super rare ones, but that you're going to see on like TV all the time, right? So dissociative disorders, it's like the basic definition of a dissociative disorder is that you're avoiding stress while gratifying needs still, right? So you dissociate from your core personality.
And your brain just kind of does it.
Yeah, from great stress. Yeah, and usually, it's not like, it's not like don't like worry all these people that they're going to wake up with two personalities because they are extremely rare. All of them are extremely rare, especially multiple personality disorder, which I would say is like the most famous because of like TV and like also going on a tangent here, like it upsets me how much we use, especially dissociative disorders, but any psychiatric disorder as a plot point in a horror movie. Like, I don't know why we haven't gotten away from that.
Yeah, that's a good point.
It is absolutely astonishing to me that we haven't like, as a society, recognize it like that's not okay. There was something I saw recently. We put
so much emphasis on mental health, and then all of our horror movies have like.
There was something I saw recently where I was talking to our sister Kendra about it, and she was like, "How did you like the movie?" And I was like, "I'm just kind of discouraged that they had to use that as a plot point." I can't remember what it was, but yeah, there's so many like big famous movies that are like, "Oh, that twist at the end, like he had 18 personalities." And it's like there's people that like actually struggle with this stuff, like, and defining like just because someone has a disorder that makes them the scary monster in the movie is like really, it has always bothered me.
It's a good point.
But we tend to fear what we don't understand, and I think that's where that kind of stems from, but that's why we need to understand it better. So anyway, long story short, dissociative disorders, you're avoiding stress, you're still gratifying needs. Couple examples: psychogenic amnesia, that would be like you don't remember something because it was a traumatic event and your consciousness has buried it. Okay, so real thing, like it's not just a movie thing, like you have buried that.
And that happens. I mean, like childhood traumas and things that people like literally don't remember because it's almost like a protective mechanism.
Yeah. And there's a lot of therapy that involves, trying to remember that in order to like pull it back to the forefront, deal with it, and then be better for it. A fugue state.
This is the one that I think
it's like you just run away.
Yeah. No, these people like will all of a sudden like dissociate and then they'll just like leave town and they'll go like function fine. They'll like go like live a life for like a month or so. And then like, you hear these stories.
They have like a second family or something like that. Like the people that have like a second family in like Asia all of a sudden is because they like a lot of times. Well, it's like fugue state. I guess
that's just an excuse.
Multiple families. Anyone who has multiple families, you obviously have a dissociative disorder. Is basically what I just said there, and I would like to redact that from the record.
Perfect. Yeah.
But no, like sometimes people are like, I can't handle this anymore, and then they just sort of like decide to forget and they move off.
Story recently where like this woman went missing and they couldn't find mom. Like they don't know what happened to her. Not like an older lady, like she's like in her 40s or 50s. And then
her name was Mom, or she had children.
She had children.
Oh, okay.
Like, yeah. No, her name was that Mom. But they couldn't find her. Right? She had children. She was like in her 40s, 50s. She was gone for like a month, and they found her in Arizona. And she's like, I'm gonna be honest with you, like I don't remember why I came here. But she had been like living fine. She's like got a hotel and was just like living her life and.
But obviously interrupting your life because where's mom?
Because where's mom?
Yeah, exactly
right. I think like your comment about the multiple family. I think like it's like fugue state is much more more diagnosed than the other ones.
Yeah.
Because for some reason, when men get caught with a second family, they have a fugue state.
I was about to say, like, it to me, I know this is terrible, like tying humor into it.
I don't remember any of that.
But that whole like narrative of like he went to get the milk and he never came back kind of thing. Like,
right, yeah.
Fugue state.
Fugue state.
Super stressful, dissociates the personality.
Yeah. So
depersonalization is when a patient experiences a loss of sense of oneself. This happens a lot of times in youth. All of a sudden they like wake up and they feel different. And they don't know why, they can't put their finger on it. And that can cause all kinds of issues, moving from there. So, very common in youth. It is a dissociative disorder, usually caused by, a stressful event. Again, this is avoiding stress while still gratifying your needs. So it's a way that the mind protects itself. But usually it's like some sort of childhood trauma. And then they experience, all of a sudden they feel like they're missing a part of themselves. All right, now moving on from there, personality disorders, distorted personality development. And
these ones are hard.
Yeah, I know. That's why I just have like a list of them. So like some examples: paranoid, antisocial, narcissistic, avoidant, obsessive compulsive disorder. Like this is all like your personality development was disordered, usually when you're growing up. And because of that, you are experiencing like atypical social skills a lot of times.
And the reason this is difficult is because society, especially, I think like when these were defined, it was like, here's normal behavior and here's abnormal behavior. And like, you may not be seeing things or doing things, but like you're not acting normal. And like nowadays we're much, for better or for worse, I don't know, but like we're more tolerant of people not being quote unquote normal. Like we don't like to define normal as like, cause everybody can be different.
Right.
The problem is that there are some certain things like if you're being a jerk all the time and disrupting my life because you're like, I feel like maybe you might have a personality. So,
well,
I mean, like it's like it's a difficult topic because of that.
We are at a weird place in society right now where it's like we're accepting of different, which is good, but there is like a line that we have to draw at some point where like if you can't function in society as society is, for better or for worse, like that's a dysfunction. Mm-hmm. So like
it may not
that's a mental health issue,
right? I mean, and it may not be like wrong. Like, we're not saying that's wrong, but currently in society, like society today could be wrong. But if you're not functioning well in society today, that is a disruption. Like that's a disruption to you as a person. So like now, I'm not saying that we're not saying that you need to like go get treated for that necessarily. But you kind of have to.
I would kind of argue that. Yeah, I think sometimes
it depends, and if you feel like it's disrupting your life,
you do.
I guess.
Like, and that's what's so weird is I feel kind of like culture can define what sicknesses.
Yeah, absolutely.
In a way,
right. Especially in the mental health space, which is very interesting.
So, yeah, I don't know. Also, like, be careful using some of these terms. Like, you can say someone's narcissistic. Don't call someone a narcissist necessarily. They might not be.
Yeah.
Like, it might be like a diagnosable condition. So, I don't know. It's so weird. Like, psychology is so hard with that. You know what I mean? Yeah. Like, you want to have, like, the intuition and understand people's behavior in general, but you don't want to put everybody in a box like we talked about earlier. Right. So, all right. Last thing that we want to talk about is just kind of a quick overview of like treatment. And again, we're not going to talk about individual meds. We're not really even going to talk about like types of treatment like behavioral therapy or cognitive therapy or anything like that. What we're going to talk about is kind of general things that you should do when you're interacting with patients.
Or the affective treatments of like when you're dealing with a acute episode of psychiatric disorder or just generally engaging with these people as a healthcare provider type of thing.
Yeah, exactly. So a couple things. Safety, obviously, priority, you and your patients, right? So never leave a suicide patient alone. Consider if a patient is a danger to themselves or others, then you do have to consider restraints. You will have different protocols or standards of care involving restraints. So depending on like, I'll tell you, it was a challenge for me moving from like paramedicine, where I had a lot of freedom of restraints within my protocols, to like nursing, where we're not allowed to restrain at all at my current hospital. Like we have to allow security staff to do that. Even if it's like ordered restrained, that was tough for me. Like I felt like a tool in my tool belt was taken away to protect myself. You know what I mean? So those can be things to wrestle with, right?
But that's one thing in the ER with restraints. Because like then like for in the emergency department, it's like chemical restraint versus like physical restraint. And like sometimes chemical restraint is safer because if someone's really fighting against physical restraints, they can hurt themselves. I always erred on the side of that, like I can always put restraints back on. You know what I mean? Like, and like the security staff didn't love that because they had to keep. But like again, as soon as someone was calm enough or like agreeable enough, I would try to take them out of the physical restraints. Because again, it's sometimes easy just to like follow that protocol and be like, oh, nope, you're in here now for 3 hours. We'll reassess then. It's like, well, no, I mean, you know what I mean? These are human. But obviously you can't do that with chemical restraints.
Yeah.
You just keep reversing.
So that was what was interesting too. Is
the medication. And
in my, where I practiced paramedicine, like we had chemical restraint. Like we could pretty liberally use chemical restraints if we needed to. Like we needed to kind of prove that they posed a certain amount of threat, and like, you know, we could like snow people. But there's like a lot of places that's like, how did you ever have those protocols?
Well, and it's hard too, because again, like if you're trying to protect yourself and others, that would be the reason that you need to. But at the same time, as soon as you chemically restrain someone, or like basically what we're saying is give them a medication to like make them not as aggressive. Now so I can't assess them either.
Right.
I can't diagnose anything or assess or see how they're doing or if they're improving until that medicine wears off. So it can really delay their treatment in the long run. Obviously, though, like if someone's going to hurt somebody, you got to be careful.
So yeah, restraints are something that you got to consider. Physical, chemical restraints. It is worth talking about de-escalation and rapport building, because that's going to help you in any of those situations. And we're not just talking about combative patients. So like de-escalation and rapport building is important when you're treating someone who is not a threat to you or others. De-escalating their perception of their issue is really important, right? Oh my gosh. Well, like we talked earlier, when I have the flu, I want to know or when I have strep throat, I want to know it's okay to have a sore throat. So like, hey, if you have a dissociative disorder, you want to know that it's okay to have these symptoms. Like that's normal within that symptomology, and we can take care of those things.
The worst thing you can do is get upset. As soon as you start getting upset, they're going to get more upset, like especially in an acute episode. Like one thing I never understood in the hospital is when like, now if they're suicidal, you need to protect them, right? But when like a mental health patient would get up and like take off and try to like get out, I never really understood why like hospital staff would like try to tackle the person.
Would chase them.
Yeah.
It's like not going to get out.
Like let them go. I mean, you can call the police and get them later. But I just never understood. Yeah. I would get out of the way. I would just move out of the way. They're like, why didn't you grab him? I'm like, why am I going to grab that guy? He clearly wants to leave. I don't know. It's just like, you know what I mean? Like, I mean, again, I think you have to.
It's funny. You're talking so ER right now. And I had to, when I was doing the research, I had to like think way more nurse than paramedic because like, you're thinking of psych patients as combative patients or people trying to run off and stuff like that. Like if you're just talking about someone like with depression, like there's still de-escalation in that. And there's still, or like suicidal thoughts. Like there might be a harm to themselves that they're considering. So like we can de-escalate that by talking to them about the issues.
I used to have very real conversation. I mean, we obviously have people who had suicidal ideations and come into the emergency department all the time. That's their entry to care a lot of times. Like they needed to, and I would have conversations all the time, like very real conversations, like do you think you'll hurt yourself? Like do I like do we need to do we, you know what I mean? Like me and you need to take steps to make sure you're
right.
You'd be amazed at how like honest and open and like I said they as long as you're caring for them in that same way you'd care for someone who has chest pain or someone who it's the same thing. So
yeah, so I think no matter the condition, like rapport building is just so important to kind of debunk and demystify some of the surrounding, you know, weirdness that people have towards these conditions. You know, they're medical conditions. Like we're medical providers. We need to treat them. So, you know, develop a relationship with them so that you can be a team with your patient and treat their condition. Couple things, medical conditions, like true medical conditions in the sense that like things going on with their body, you know, things that we can like recognize pathophysiology in, like be careful not to ignore those, what we would consider to be medical problems in a psychological assessment, right? So again, like I hope the audience understands, like when we say medical issue versus psychiatric issue, we are not playing down either of those issues or saying that like psychiatric medicine isn't medicine or anything like that, but there are things that are happening in the brain versus things that are happening to the body that might cause those issues, right? So if I have someone who's experiencing hallucinations and delusions because they're drank a bunch of alcohol and they're like have alcohol poisoning now, like I need to be able to recognize that underlying cause of a medical condition and then therefore those psychological symptoms. And that's where it's so important. Like recognize that your job is to recognize the symptoms and label the symptoms, not label the condition behind it.
That's the thing. A lot of diagnosing a psychiatric or psychological condition is first ruling out all the potential causes of it. Only until you've ruled out that it's not all these other things can you say, okay, well maybe this is, you know what I mean, like more of a psychiatric type of issue versus like, so especially as if you're a first responder, you know, I mean, really, like nurses, physicians who are not psychiatric, like your job is to get them on the path of making sure it's not all those other things, right?
Right.
Like the worst thing you can do is like have someone come in, especially like in an emergency setting, and just chalk it up to a psychiatric disorder.
Right.
Especially because a lot of these disorders, because they're disruptive, people turn to medicine or turn to alcohol or turn to other things in order to like self-medicate or like help themselves. A lot of times there is a lot of like comorbid medical conditions going on that need to be dealt with first. So.
And I think recognizing that psychiatric conditions are based in chemicals and are very medical in that sense of the word, like helps us out a little bit. So like your job is to look at the patient and be like, he's experiencing, you know, delusions or hallucinations. Okay, is that because of a chemical imbalance of his brain, because of a production issue, almost like you can consider like an autoimmune, like because that he just does that, or is he having too much of those chemicals or too little of those chemicals because of some other outlier cause, right? So, and that's the job, is to kind of investigate and figure that out and identify it. So just be careful not to ignore medical problems. Or as another caveat to this is like, don't ignore a psychiatric person who sees somebody in the corner and is having like those kind of delusions and hallucinations. And then they're also like, and I have crushing chest pain. Like,
right.
They're not making up the person in the corner. They perceive that person in the corner. It's not based in reality, but their chest pain might be based in reality.
And I always say this too, like people, like your frequent flyers, like people call it frequent, like people who come and seek medical care all the time. Like we had this one kid, I remember he was like in his 20s who would come in, I mean, literally almost every day for chest pain. And he very much had like hypochondria, like, but like the reality is that like one day he could roll in having a heart attack. And so you have to balance the, you know, those two things. So just like to your point, like just because you have a psychiatric condition doesn't mean you can't suffer from a heart attack, a stroke, and all these other pieces. Right. So we really have to be cognizant of that. But
exactly.
Awesome.
So so summing it up, safety, you know, don't rule out medical conditions before you truly rule them out, I suppose. De-escalation, rapport building, reassurance, and calmness is so important in this type of care. And then if you're a pre-hospital provider, transporting them to the appropriate facility, or if you're an in-hospital provider, making sure that they get to either the correct floor or the correct doctor, or maybe they need to be transported to a facility that can better handle their needs. So that is our little review on psych conditions. More to come in this area of medicine as we kind of grow and learn with you, and we'll probably start tackling some medications soon, talking about, you know, serotonin reuptake inhibitors.
Only that one. We're going to do a whole episode just on that.
I mean, we could, though.
Yeah,
That's what's so...
Yeah. Awesome. Well, hey, thank you guys so much for listening. Again, if you want to get a CME CAPC credit, if you're a first responder, EMT, paramedic, that type of thing, check us out at guardiancme.com. And if you have an in with the ANCC for nursing credits, let us know so we can start getting you the nurses out there credits as well. So awesome, guys. Thanks so much.
Stay sweet.
Hey guys, thanks so much for taking a listen. If you are studying for the National Registry exam, we're here to help. We have a National Registry prep program to help you pass that exam. Check us out at guardiantestprep.com. If you'd like continuing education credits for listening to our podcast or watching this on YouTube, follow us at guardiancme.com. 100% free CAPC credits. No matter what state or country you're in, we're here to help. So again, we thank you so much for listening. We hope you have a wonderful week.